Thank you everyone for joining this webinar. Um, my name is Mesfin, and I work as a lecturer at Newcastle Business School at the University of Newcastle in Australia. So today's webinar is part of this project on joint action on integrating the European reference networks into the national healthcare systems. And today's topic will be about discrete choice experiments, or DCEs, and how can we use them in order to understand preferences for different organizational models of rare disease care. If you go to the next slide, please. Yeah, then, okay. Yeah, so this is the agenda for my presentation. So we'll start with why preferences matter for rare disease. And then I will introduce what a discrete choice experiment is and some discrete choice experiment terminology. And then I will talk about the DC workflow for rare disease, like the different steps that one has to follow when conducting a discrete choice experiment. And then I will demonstrate what is called the attribute scorecard, which is an important part of the attributes development stage when conducting a discrete choice experiment. Yeah, and then I will talk about the analysis and how we analyze and interpret data from a discrete choice experiment. And then finally, how we can use the discrete choice experiment results for policy making, or how can we embed the DC results in the development of, let's say, online decision aid tool, or how can we use in sort of economic evaluation like cost benefit analysis. So just to begin with, so let's talk about why preferences matter in rare disease. So if you can click next, yeah. So as you know, rare disease care is often fragmented, and patients and caregivers, for instance, they might see several providers, and also there could be cross-border travel that may be needed, and travel can be long, and there could be uneven access to innovation. And of course, access to innovation may depend on where people live or where people happen to live. And at the same time, there are different organizational models on the table, including the networks, the national centers, national plans, telemedicine, and public-private partnership models. So given these different organizational models, we need a way to kind of quantify or rank these options and elicit preferences. Um, if you proceed to the next one, please. Um, and of course, when we think about ranking of these options, so there is a fundamental question here, like from a system point of view, the key question is which of these options or organizational models is more efficient or easier to implement? But from a patient or from the caregiver perspective, there are other questions that we need to address, like which of these features or which of these characteristics do people actually prefer, and by how much? So that is very important question that we need to address. So if you next, please. Yeah. And then, for instance, do they value being linked to the European reference network more than, for instance, shorter travel time? And how much do they value access to innovations compared to other attributes or other characteristics like waiting time or out-of-pocket cost? So the discrete choice experiment allow us to quantify this kind of ranking, like how much more patients value one organizational model compared to the other, or one configuration over another configuration. So what exactly is a discrete choice experiment? So let me try to just explain what it means exactly. So this is one of the stated preference elicitation techniques, which has been frequently used in health economics to address a range of research questions. And it's a quantitative survey method, which we present respondents with two or more hypothetical options. Basically, the options could be hypothetical, so we provide them two or more options, and then where each option can vary or can be characterized by a set of, let's say, attributes or characteristics. If you can click next, please. So there is a set of common attributes that we use in order to describe the alternatives, for instance, the program care. And then these are shown at varying levels. And then we ask respondents to choose their preferred option. And from these choices, we actually give them like repeated choices. And from these repeated choices, or from the observed choices, what we do is like we infer how much value people attach to the different organizational models, for instance, how much value they attach to access to innovation or out-of-pocket cost. So we can address those kind of questions using a discrete choice experiment. And then based on that, we can, for instance, simulate what share of patients would pick, for instance, an European reference network-based model. Let's say if travel time is more than 60 minutes, but access to innovation is full and cost is quite moderate. If you can proceed to the next, please. Um, and these are essential DC terminology that anyone who is doing a discrete choice experiment use. So we frequently use these terms like attribute, label, choice task, utility. So an attribute is like the characteristics of the good, or we call it like feature. So it's simply the characteristic of care that varies in this particular context. So for instance, if you take travel time, it's an attribute. And in the rare disease context, the type of organizational model could be an attribute. And the level means it's the value that the specific attribute takes. So for instance, for travel time, the level could be less than 30 minutes, it could be greater than 60 minutes, and so on. And then specifically for the type of organizational model attribute, the levels could be national center versus telemedicine, or the public-private partnership could be considered as levels. And then the choice task means the decision between two options. So for instance, if we give the option, or if the choice task is if it consists of two programs, let's say choice between program A and program B, then we call that a choice task. And there is what is called utility. This is simply a numerical measure of the strength of preferences. So the higher value means there is a stronger preference for that specific characteristics. Okay, next slide, please. So just to kind of explain this concept easily, let's take like a daily life DC example. Let's suppose that you want to kind of book a hotel online. And so this is about a hotel booking decision. So there are a number of factors that we need to consider when we make a hotel booking decision. So for instance, you can consider these attributes or these characteristics as attributes of a hotel booking, like you consider the fitness center, the check-in time, the price, the amenities, the availability of breakfast, and things like that. And then after that, you make your booking decision. If you go to the next slide, please. Yeah, so let me try to specifically give you a specific example. Like imagine there are two hotel options for you in your next booking decision. And the question is, how do you choose? Okay. And the answer for this depends on, a number of factors. So it depends on what you value most. And then in most booking decisions, you see a number of characteristics. So you consider the price of the hotel, like per night, whether there is a room view, availability of breakfast, what about the cancellation policy? So we consider all these factors, and imagine these are like the kind of options that you have when you make a hotel booking decision. So would you choose the first hotel A or B? So the first one seems like cheaper, it has a city view, but then we don't have breakfast and the cancellation policy is non-refundable policy. Or would you choose the other hotel, which costs 120 euros per night, which has a sea view, continental breakfast, and the cancellation policy is flexible? So we ask these type of tasks. So what a discrete choice experiment does is it presents these type of choices systematically in order to measure the preferences that people attach to the different factors. So some people might attach more weight to the price, some others might attach to the breakfast availability. So we use a discrete choice experiment in order to uh, basically understand, or in order to measure the preferences or the relative importance that people attach to the different characteristics. Now, what type of results do we get? So for instance, we get like a number. So we use some standard models from the observed data. We kind of estimate, okay, the weight that people attach to the different characteristics. So for instance, you might get 0.5. So this means on a preference scale, travelers strongly prefer a room with a view, with a sea view, compared to no view. So that is a very simple kind of interpretation for these type of results that we expect to get. This is just an example. It might be 0.35, for instance, for flexible cancellation policy. It means that this is positively valued. And then for the cost, you would expect to get, let's say, a negative number. If you click next, Sylvia, please. So for instance, this means that this is as expected. There is negative. Higher cost means reduces the probability of choosing a hotel. So this is the kind of results we expect to get in a discrete choice experiment. Can you proceed to the next, please? Um, and of course, how we interpret these results. So like I said, if we have a positive utility, it means that it increases the probability of choice. And there is an important metric or an important metric that we get from a discrete choice experiment, which is called willingness to pay. So instead of directly asking respondents, how much money are you willing to pay if I give you like a hotel with a sea view? This is an indirect way of estimating how much money people are willing to pay if you improve the healthcare services, for instance. So this is simply obtained by dividing the coefficient of the sea view by the coefficient of price. So what it means is that if you just give me a hotel with a sea view, then respondents are on average willing to pay 25 euros extra for that improvement. Then how can we use this type of results? So hotels, for instance, can bundle this type of characteristics based on the estimates, and then they can basically use these bundles in order to boost their bookings by a certain percentage. So what we do in healthcare is exactly the same. So we just simply replace, for instance, room view with access to innovation, or price with treatment cost. And the choice mechanism and the logic of choice is exactly identical like the hotel booking choice. If you can go to the next slide, please. So then the next question is why this type of instrument for health and in particular for rare disease? Next slide, please. So, we may use, let's say, other traditional surveys, like simple surveys. For instance, you can use like Likert satisfaction surveys, which captures like if people like or dislike something, like for instance, in terms of the type of organizational models, just to understand whether people like the European reference network compared to other models. And then you ask people to rate each option, let's say from 1 to 10. And then what we can learn from here is like, okay, people might like the European reference networks, or they might dislike long travel and things like that. But then the problem with this type of surveys, it cannot allow us or it cannot tell us how much people value one feature over another. Like it cannot, or we cannot learn, let's say, how much more people value the European reference networks compared to other type of organizational models. But then the DCE quantifies these preferences. It tells us how much value each attribute or each level adds. So that is very important. And in a discrete choice experiment, we present some sort of realistic choice scenarios with multiple attributes. And then based on that, we can get utility weights, relative importance of an attribute, the willingness to pay, those kind of things. And another advantage of using this type of model is this is grounded in what is called random utility theory. It has rigorous theoretical and behavioral foundations. It allows us to estimate willingness to pay, willingness to travel. So we can get these kind of measures, which ultimately can help us to inform some policy. And we can simulate, for instance, uptake or policy impacts. So if we change the package or if we change the organizational model, what would be the predicted uptake? We can get this kind of information. But in addition to that is we have data limitations, in particular in rare disease, right? Because this kind of condition affects quite few number of patients. And therefore, if we have to rely on traditional studies, then we may need to kind of to get like a large number of respondents or larger sample size. So that could be quite challenging in this specific disease context. However, discrete choice experiments can give you reliable results even with a smaller number of respondents, like from 200 to 500 respondents. If you can click to the next, please. Okay, then what type of output do we expect? And then I will go through the different steps, particularly focusing on this specific project. So there are a number of metrics that we can derive once we get the discrete choice experiment data. One is the utility coefficient for each attribute level. And then if we see basically whether that is positive or negative. If it is positive, it means that attribute is preferred. If it is negative, it is less preferred. And then Basically, it shows how each attribute influences the choice probability. For instance, just take an example. Okay, if you get like a coefficient of zero 0.7, like for access to full innovation compared to no innovation, then it means that access to full innovation is preferred. Traveling more than 60 minutes is less preferred because it has a negative sign. So we expect to get something like this. And another metric that we can get from this type of exercise is what is called relative attribute importance. What is the relative weight of each attribute? What is the relative weight of the different organizational models in overall decision making? And then we rank these characteristics in terms of percentages, like, okay, 30%, 25%. So, access to innovation is the number one ranked characteristic, so it's the most important. So we can get this kind of information from this type of analysis. And the other important metric is the willingness to pay and willingness to travel. For instance, we can convert the preference estimates, the utility coefficients, into something tangible, if we, or in terms of time or money, for instance. Okay, we could say like patients are willing to pay about this amount of euros per month in order to have, let's say, a dedicated coordinator compared to something else, or a baseline or a reference point. And then finally, we can estimate what is called predicted uptake. So what if we can address what is called what if scenarios? So what if I change, the model, and instead of, let's say, telemedicine, what if I change the European reference network like model? What would be the uptake? What is the percentage of uptake? So we can get these kind of estimates using this model. Next slide, please. Yeah, so what happens in rare disease? So as you know, rare disease care involves organizing services, it's not just picking a drug. And of course, the options can differ on a number of factors, on a number of characteristics. So it depends on coordination, travel time, access, out of pocket. And then what the discrete choice experiment does is that it can rank these combinations of these features from the patient perspective or from the stakeholder perspective. And it can help us understand the trade-offs that people are willing to make. And then next slide, please. So what are the process? What are like the different workflow process in particular for this project? So there are a number of steps that one has to follow when conducting a discrete choice experiment, and I'm going to explain these different steps. So the first thing is we need to conceptualize the choice process. So by this I mean, like, who are the respondents? Are these like people living with rare disease? Are we considering the parents or the caregivers? What type of choice are we considering? Is it like a binary choice, choose between program A versus B, or is it a multiple choice kind of question? What type of like, what do the alternatives look like? Is it like, so we have what is called labeled and unlabeled alternatives. So by unlabeled, it means that we have, for instance, the programs, like, so we have the programs in terms of, let's say, program A versus program B. And this is unlabeled because whether you call it program A, B, or 1, 2, or option 1, 2, it doesn't really matter. Whereas in the case of label design, like if I ask you to choose between transport A and B, that is called unlabeled design. I can call it option 1 and option 2 in terms of transport. I can call it transport 1 and 2. And then having these kind of labels of the alternatives does not really affect, choices. But then if I ask you to choose between bus versus train, then there is a label here. So the label could affect your choices. So we need to decide, are we providing unlabeled alternative or labeled alternative? And then we also need to consider, like, should we force people to make a choice? So for instance, in the hotel booking choice, I was asking like to choose between two hotels, option hotel A versus hotel B. That is a forced choice. But then in reality, we don't force people, right? So in order to mimic with the reality, what we need to do is, like, should we include an opt-out option? Like if people don't like both the rare disease program options, like program A and B, are we giving them like an opt-out option? If they don't like, can they choose neither of the two programs? Or if we have to force them, is there any justification for that? If a forced choice was used, then is there any justification for that? So we need to address all these things in the conceptualizing process, or in the conceptualizing the choice process. Next slide, please. And then the second step is about generating the list of attributes, right? So if you remember in the hotel choice, we have attributes like the booking policy, the price, and availability of breakfast, and then of course other characteristics. Now, how can we select those attributes? So there are different ways. We follow usually in healthcare a multi-stage process. We review the literature, policy documents, published articles. Sometimes we do discussions with experts, stakeholders, and we interview patients. And then with this kind of process, we come up with a long list of attributes, right? So if you remember in the hotel booking example, I gave you only 4 characteristics. That is easy to understand, easy to compare different options. But what if we have a long list like the one that you have now? So we have about, let's say, 11 to 13 attributes. So the problem is it's really difficult to include all these characteristics in one choice task because it is going to be cognitively demanding for the respondent. So we need to find a way to reduce the number of attributes. So there comes the importance of the attributes scorecard. Can you proceed to next, please? Yeah, so like I said, we have 11 to 13 attributes, which are too many for one discrete choice experiment. So we need to reduce the number, so which implies that there is a need for prioritization, and the attribute scorecard comes here. Okay, so as some of you know, Raushan, who is part of this project, might have sent you the survey link for this project, which we call it the attribute scorecard. So what I'm going to do is like to give you like a quick demonstration of the scorecard in order to show you how experts can allocate different points and how can we use these results in order to basically refine and then come up with a manageable number of attributes and levels. Next slide, please. So the idea is very simple. Like I said, the objective is to reduce the number of attributes to something that's manageable. And then we use a point allocation system. So out of 100 points, okay, can you please allocate these 100 points to different attributes based on the importance to you? And then we have got very specific instruction to the experts. It says like you have 100 points to allocate across all the attributes. And if you think a certain attribute is not relevant, then you can keep it blank, or you can put it like 0 if it is not relevant. And there is another row which says other. And in the other, if you think there is a missed attribute, then you have an opportunity to add there and then to give a value or to allocate a point out of 100. And the whole attributes or the whole allocation should give you a total of 100 points. And then based on that, like we get the data, and then we do some averaging, and then we take the mean, and then based on that, we basically rank the attributes based on the importance to the experts. Can you go to the next slide, please? Yeah, so from the survey, you might have seen these attributes. So there is an attribute called type of care model, care coordination, and things like that. There is a small box there where you would be allowed to put like points out of 100, and then you save that. Basically, just let me give you like a very simple example. Suppose I am one of the experts, and then I think the type of care model is important, and I give it 25 points out of 100. Care coordination is important, and I give it 15 points. It's less important compared to type of care model. That's why I give it 15 points, and then I save it. And the next, we have travel time, and then it's important, but it's less important compared to the first 2 attributes, and then I give it 10 points. And then up to now, I have already allocated 50 points out of 100. Now I'm left with 50 points in order to allocate or distribute to the different or the remaining attributes. If you go to the next slide, please. So then you see other attributes, access to innovation. It's important for me as an expert, and then I give it 15 points. Well, continuity of care, it's important, but it's less important compared to the others, and then I give it 5 points. Treatment benefit, I give it 5 points. And so far, the total, as you can see, is 75 out of 100, and I still have 25 points to allocate to the remaining attributes. Can you go to the next slide, please? And then you will see also the remaining attributes, like attributes 7 to 9. Next slide, please. Yeah. So psychological support. So for instance, I give it 4 points out of 100. Provide a recommendation, 4 points. Out of pocket cost, 4 points. And then you see it's still 87, and I have left some points to still allocate to the remaining attributes. And if you go to the next slide, please. And then the last remaining attributes, sorry, yeah, so you have the quality of life impact, caregiver, family burden, and other. So I give it 5 for the 10s and 11s attribute, and then I don't think there is an important attribute that is missed, so I put 0 for the other option. But still, the total sum still gives me 97. So I still I'm left with 3 points, but I'm done already with the allocation of these points. So what I need to do with the total sum has to be 100. So what I need to do is like, oh, okay, psychological support. I gave it 4 points initially, but I think the points should be increased, and then I give it like 7 points because the total sum has to be 100. And then there is an opportunity for you to revise what you have allocated initially. So that's how you come up with the total 100. So if you can go to the next slide, please. So once we get all this is just a fake example, as you can see, then we create in this way. So suppose I get this data from 5 experts, and then these 5 experts gave different points according to the importance of these attributes to them. And then what I do is like I take the horizontal summation of each attribute, and then I take the average. And then based on that, I rank the attributes. So for instance, type of care model, the average score is 25. So this is the most important attribute according to the experts, and definitely this will be included in my design. Care coordination is the second most important attribute, access to innovation the third, and so on. The next slide, please. Yeah, and then there are some rules. So we keep the attributes with the highest mean points or average points. And then if we think like some of the attributes are important, like burden or support, for instance, then we retain them. Sometimes we merge conceptually similar attributes, like for instance, coordination and continuity of care might be merged. And then the other rule is we have to limit the number of attributes from 5 to 7, 4 to 7, and so on, because we want to make the design manageable, and we want to reduce cognitive load. Otherwise, if we increase the number, then it would be really difficult for the respondents to kind of compare all the attributes and to make the required trade-offs. Suppose based on this type of exercise, we come up with these 6 attributes. So let's say the final list includes the type of care model, care coordination, continuity, travel time, waiting time, access, and out-of-pocket cost. So these are like the list that will be included in my experimental design. So if you go to the next slide, please. But then there is another step. So we have basically selected the attributes, but then we need to assign labels for that. Okay, the labels could take, let's say, 3 to 5. So which means that we have like say out-of-pocket cost. Then the label means the value that this out-of-pocket cost takes. Could be like $50, 100, 120, and things like that. So we might use the same kind of sources, guidelines, clinical experts, policy documents, some kind of discussions with experts to come up with this list of labels for each attribute. Next slide, please. Then suppose based on this type of exercise, we come up with this type of labels. So for instance, for the type of care model, we have 5 levels. For the travel time, 3 levels, waiting time, 3 levels, access to innovation, 3 levels, and out-of-pocket cost, 3 levels. Okay, so this is something that we need before doing the experimental design. Next slide, please. Yeah, so the next task is to kind of combine the different levels, because we want to create a choice card, something that I showed you for the hotel booking example. So we want to create these kind of attributes and labels in a kind of choice task format. So here there is what is called full factorial design, fractional factorial. Basically, if you take all the possible combinations, which could be in thousands, it's really hard and difficult and practically infeasible to kind of present all these thousands of possibilities to the respondents. As you can imagine, it is cognitively challenging, very difficult. So we need to find a way to reduce the dimensionality of the design matrix into something manageable. And then we have mechanisms for doing that. We need to decide like how many alternatives to ask per task. 2 alternatives. Should we include, let's say, opt-out, like I was trying to explain before, or should we force them? And then how many choice tasks per respondent, right? Should we include 8, 10, 20, 30? So usually we may generate up to 30 choice tasks, 30 tables which consists of the options, right? And then there is what is called blocking technique. So the blocking basically is if you have 30 choice tasks, you divide this into 3 groups or 3 versions. And the reason is we want to reduce the cognitive burden that could happen to the respondents, right? So that if you have 30 choice tasks, you then block that or you divide that into 3 versions so that each respondent is expected to answer only to 10 choice tasks. And then in some cases, you might find some of the alternatives implausible or unrealistic. Then the question is, how do you define implausibility? Okay. And then if you find some alternatives implausible, then how can you address? So there is a mechanism because we use some kind of software which is called engine in order to generate these choice tasks. So you can constrain the design. Basically, what it means is like if you find some combinations of attributes in a certain program or alternative, please reject them. Then the software will reject them and then will give you some of the plausible combinations that will be included in your survey. So this is just an example, just manually created example, but the actual design should be done using a software like Engine or other similar software. So as you can see here, this is one of the choice tasks. So you can see the features are like in the first column, as you can see. So the programs are described by a common set of features, and then but the program A and program B could be different, as you can see. So would you choose program A, which has that characteristics that you see on the screen, or program B? So that is the type of question we'll be asking. And then if you ask only the first question, you're simply forcing the respondents. It will be like a forced choice. But in reality, do we force people? So we want to mimic with the real world or with the real situation. So to do that, what we can do is like we add a follow-up question. Like if you were given the option not to choose any of these programs, would you still stick to your original choice, or would you now change your mind and then prefer neither of these two programs? So we call this dual response format design. And the reason why we do that is because we want to add realism to the experiment or to the model. But then this is not the only choice task that we present to the respondents. Like I said, this is repeated. This is the first choice task, for instance. If you go to the next slide, please. And this is the second choice task. Like if you see this task, at first glance, the previous choice task and this task might seem the same, but if you closely look at the program features, the two are different. What's common between the previous choice task and this second choice task is the common set of features. The attributes do not change as you move from one choice task to the second. What's changing is basically the levels. So in the previous case, we did not have, I guess, telemedicine consultations, or it was in the second program. We did not have national care plan. Now the levels basically change as you move from one task to the other. Can you go to the next slide, please? And this is just an example of the third choice task. So as you can see, common features, but the programs are different if you closely look at them. So we repeat these 10 times. And as you move from one task to the other, the common features or the attributes do not change, but the levels change from one task to the other. So this is a kind of repeated choices that we ask or we present to the respondents. And it's based on that repeated choices that we observe, we infer how much value they attach to each characteristic or each feature. Okay, next slide, please. Then now you have, let's suppose you have the list of choice tasks. You followed from step 1 to 4, and then you have generated the list of choice tasks. Let's say 10 choice tasks per respondent. Then the next task is the questionnaire design. We need to create the questionnaire, which the actual survey, which includes like the background information, the contextual information. We need to define in a very layman friendly language, like what exactly is each attribute? What do the levels mean? You know, we need to kind of explain that before you present the actual choice task. Okay, so where the task instructions are appropriate. So we need to answer these type of questions, at least in the fifth step. And sometimes, if you have seen, I have included little emojis in order to kind of capture some of the levels. So, you know, it's just to kind of ease understanding or comprehension. So sometimes we add textual information plus visuals, okay? And then there are some good practices. We have to, you know, provide attribute descriptions in a very plain language, and we have to include some practice questions, which we call it warm-up choice task. And the purpose is basically to familiarize the respondents with the content of the choice task before they actually start or see the actual choice questions. We usually add one up to two kind of comprehension checks or cognitive test type of questions. So for instance, we give them two programs, okay, or program A and B, and then we ask them which options has the shorter waiting time. So they only need to check like which program has the like smaller or the shorter waiting time, looking at the number of minutes. And that is basically used in order to understand or to make sure whether respondents understand the exercise that we're providing them. And then we present the actual choice sets, the 10 choice sets. And then after that, after the DC, it's a good practice to include some debriefing questions. How did they make the choices? Is it based on, considering one of the characteristics, or did they compare all the attributes as a package? How did they, make their choices? And what was the choice question difficult for them? And then we also kind of give them like an open box in order to provide an opportunity for the respondents to give comments and things like that. Next slide, please. So now we have designed the questionnaire, okay, the survey. And then the next thing is we need to pilot this. And there are two kind of piloting in this type of exercise. We need to do qualitative piloting and then quantitative piloting. And then for that, there are a number of things that we need to check here. But then the whole purpose of doing that is just to make sure that respondents understand all the characteristics, all the choice questions as intended. So for that, we do qualitative interviews first. And in particular, in this type of exercise, and from my experience, we use what is called think aloud interviews with some selected group of, let's say, the target or potential respondents. In particular for this, we might do the think aloud interviews with rare disease patients in order to check whether they interpret, all the questions, all the attributes, all the choice tasks as intended. So we do this kind of think aloud interviews until we reach a kind of saturation point, until we see that the questionnaire is no more improving. And then we do that with 5 to 10 participants. And then once we have like an improved version of the survey, what we do is like we go to the quantitative piloting so usually we do like 5 to 10% of the total sample. So if you have, let's say, I don't know, 250, then we take 5% or 10% of that, and then we basically send the survey to these participants. And then once we get the data, we check a number of things, at least at this stage. We check whether the signs are as expected, how much time it takes to complete the survey, a number of things. And then if we found out some errors, then there is an opportunity for us to revise the wording. And if there are things that should be dropped, then we do all these things at this stage before we actually collect the main survey. Next slide, please. And then there are other considerations. What is your target population? Is the research question appropriate for them? And also, what are your target groups? Are we considering adults with rare disease? Are we considering parents or experts or a combination of this? Whose perspective really matters? Is it the patient or the caregiver or the family? All these kind of things should be addressed, at least at this stage. Next slide, please. And then we need to decide also the sample size and the recruitment, how many respondents to use. Well, as I said, the advantage of using this type of experiment is like you can work with limited number of sample size, and in particular for rare disease context, then it's really hard to access these patients, and the number could be quite small. So for that, this kind of survey is really, really important. So we have some rule of thumb to determine the sample size. And we use that. And then in terms of recruitment, we may use different sources. And I'm sure you know better than me about like where you can kind of target these kind of respondents. You could use patient organizations, national centers, mailing list, and things like that. So we need to determine all these things in the AIS step at least. Next slide, please. Then we start the data collection and the structure. We need to answer these kind of questions like what recruitment method was used? Are we doing this online or sending via mail? Is it web-based? What was the response rate? Did we provide or do we provide incentives in order to enhance response rates? And then if we use like, I usually use, I once used a face-to-face interview with patients with kidney failure. But then after that, I guess we have been using online kind of or web-based kind of surveys. And the advantage is it's easy. You can immediately export the data into CSV file or in a data format. So it can be ready for your analysis. If you go to the next slide, please. Then we need to code the attributes. We need to explicitly kind of explain what kind of coding we used, and is the coding appropriate, for the effects to be estimated. If we have, let's say, categorical kind of labels. So, for instance, for the type of organizational model, then we have 5 levels, and then we kind of should create 4 dummy variables, and then we should take one of the labels as a benchmark. For instance, I could take the private-public partnership as a benchmark, and then create 4 dummy variables related to the European reference network, related to telemedicine and things like that. And then usually for the cost attribute or characteristic, we treat it as continuous because that is needed in order to estimate the willingness to pay. And of course, one kind of important point here is the coding should be explicitly reported in the manuscripts that will be prepared. And unfortunately, this is something that's missing in many manuscripts, but just for transparency purpose, it's really advisable to kind of explicitly, explain or mention how the coding was done. Next slide, please. Then now you have all the data, you coded and everything. So now comes the analysis. So we have the choice data. We put that in data format or in CSV format, or we may use R or MATLAB or different kind of analysis software. And then the next step will be the analysis. So the analysis of data from a choice experiment is based on what is called the random utility maximization framework. And this was pioneered by Daniel McFadden, who was the Nobel Prize winner in economic sciences in 2000. And according to the random utility maximization framework, if you go to the next slide, please. According to the random utility maximization framework, the utility that you get, let's say from choosing program A compared to program B, depends on 2 factors. There is what is called the deterministic part of the utility function, which is a function of the observed characteristics, that's the attributes that you selected. Now we have data about these attributes already in the previous step. We coded and we have information, right? So the first part is the utility or the deterministic part of the total utility function, which is a function of the observed characteristics. And there is another part, which is called the error term or the stochastic part of the utility function, which can be taken as like a catch-all, which captures a number of things. It could have like measurement errors, or it can capture things that are unobservable to the researcher. So we have standard models to estimate the data from choice experiment. And then you might get something like this, for instance, in this rare disease example. So beta for ERN could be, let's say, 0.7, or for telemedicine, it could be 0.3. Just this is kind of example you would expect to get once you do the analysis. Next slide, please. So we have, like I said, standard models. What we do is we start very simple model, which we call it conditional logit model or multinomial logit model, which serves as a baseline kind of model. We check the signs. Is it positive or is it negative? So is the care model European reference network, is it positive? What about travel and waiting time? So we expect travel and waiting time to be negative. The longer travel time, the longer waiting time, to have a negative effect on the probability of choosing a certain program of care. Cost is expected also to be negative. And the other thing that we check when we conduct this kind of analysis using the multinomial logit model is the significance. Like we check whether the attribute coefficient is statistically significant, and if it becomes significant based on a certain threshold, then we select attribute matters. And then, like I was trying to explain, respondents are asked, or they're asked to make repeated choices. So in a way, you can think of like as a panel data, because they are making repeated choices. Then to account for the panel nature of the data or the repeated nature of the choice to the data, we kind of extend the model. So that is what is called mixed logit model. And this model allows us to account for heterogeneity of preferences. People have different preferences. Some patients might prefer telemedicine, others might prefer something else. So to account for the heterogeneity of preferences, of course, unobserved heterogeneity of preferences, we use this type of model called a mixed logit model. There is also another model, which is quite interesting, latent class model. What we do is we kind of, we kind of estimate latent class with different number of classes. And then, for instance, you can kind of identify who are in class one. So the assumption is in each class, the preferences are homogeneous, but as you move from class one to class two, then preferences are heterogeneous. So you might find, for instance, in class one, respondents with a certain characteristics, those who are, for instance, innovation seekers. Or in class two, you might find respondents with a certain behavior like travel minimizers. And then you can kind of extend this. Who are these people? Who exactly are these individuals? Who are travel minimizers? Who are people who really like the European reference network? So for that, you can use covariates of class membership, for instance, in terms of socioeconomic characteristics, other characteristics, and then you can identify who exactly belongs to which class. So, and then you can kind of target them, and that is also another advantage of using this kind of latent class approach. Next slide, please. And then once you do the analysis, then comes probably the last step. You interpret, and then we have several kind of metrics. Like I said, you can obtain willingness to pay, how much money they're willing to pay, for instance, for European reference network based model compared to the national plan. We can calculate willingness to travel because we have travel time and we have cost, and this will allow us to indirectly estimate the willingness to pay and the willingness to travel. You can also estimate what is called or compute the attribute importance. Which attribute is the most important attribute? Is it the European reference network or something else? Is it access to innovation? You can do that. And then finally, you can simulate or you can do simulations in order to answer important policy questions like how many patients would move from a new kind of European reference linked program if you remove the out-of-pocket cost, or if you remove something else. What happens if you reduce the waiting time? What will be the predicted uptake probability? So you can do that, and that's really crucial for policy purposes, which I'm going to demonstrate how we can use that in a few slides. Next slide, please. Yeah, so the kind of policy simulations I was talking is like you can create a package of programs. So for instance, scenario one is like European reference network, linked network, specialist-led coordination, travel time takes more than 60 minutes, 1 month's waiting time. There is access to full access to innovation, and it costs $50 or 50 euros per month. So if we combine this package, what would be the probability of uptake? What is the predicted uptake? You can do whatever kind of combinations. You can create your own scenarios, and then you can see, the predicted uptake, which is really important for policy purposes. Next slide, please. Yeah, now is my last part of my presentation. So we have done this, we have followed all these steps. Then the next question is, so what? Like, we have the DC results. Okay, how can we translate this into something that is usable for decision makers? So the next presentation is about using these DC results in order to develop, let's say, sort of online decision aid tool, and how can we use them in economic evaluations or in some sort of cost benefit analysis of, let's say, comparing different programs of care, for instance. Next, please. Yeah, so what we do is we have already obtained the data from the respondents. We estimated our model. We get the estimated utilities, the coefficients. We estimated the willingness to pay, the relative attribute importance. So we have all this information. Now the next thing is, how can we use these results into something that can be usable? Okay, so well, I don't have any kind of specific example based on rare disease context, but I have done some work on loneliness intervention strategy in order to reduce loneliness problem among older adults in Australia. But the logic is exactly the same for rare disease. So I'm going to show you what type of online decision tool you can develop from the results from discrete choice experiment. If you click the next slide, please. Yeah, so here we kind of developed a tool. So next, please, if you can click to the next. And then you see there is like a snapshot of like the tool. Basically what you do is like, as a decision maker, you can create your own package of care program, for instance. So if you click on the link, Sylvia, please, then it will take you to the actual decision air tool. Yeah, if you maximize this and then if you increase the size a bit, yeah, so what you can do is, as you can see, there are different tabs. Sylvia, if you just click on the attributes tab, yeah, there you can see the attributes that we used. So basically in rare disease context, it includes things like access to innovation, out-of-pocket cost, the type of organizational model, and those kind of attributes we were discussing. If you just click on the inputs tab, Sylvia. Yeah, so that is the actual interface where you can create your own package. For instance, in terms of the type of program, suppose you click on community engagement, please. Community engagement, for the support program, community engagement. Yeah, that's the radio button where you can clickable, and then leave the method. So the reference is in-person kind of interaction. This is a loneliness reduction intervention. So let's talk, click on weekly for the frequency, please. Frequency of interaction. So these are like the attributes that I was discussing for the rare disease. So you can think of those attributes, but this is just for loneliness kind of study. And then the duration of interaction, just take, let's say it is 2-hour interaction. And then accessibility, you can access those support intervention centers within your local area, let's say 12 kilometers, up to 12 kilometers. So click on that, please. And then there is a cost slider. Just leave the method, because if you leave that, it means it takes the reference value, which is in bracket. The reference is in-person method. And then if you just use the slider and then make it to 5, please, the cost per session in terms of Australian dollars is like, okay, you keep it there. And then please click on calculate and view results. Calculate and view results. So you see that the predicted uptake is 72%, and there is a dynamically changing recommendation for that. Uptake is high, the current configuration is effective. If you just cancel that and then change something else, please. Or don't change anything, just if you go to the different tab, which says cost benefit, can you go up and then cost benefit? So there you could see like what is the benefit in terms of improvement in the quality of life of these individuals. Then we have kind of used quality adjusted life years, and then we translated that into monetary values. And then there are some cost elements. If you go down, Sylvia, you see some cost components down there. Like if you want to establish a certain loneliness reduction intervention center, if you click on that, it will toggle like the cost breakdown. You see there are some cost items. So what if I want to establish a certain loneliness support intervention center? So what do I need? What are the costs? And then you see different cost components. And this is dynamically changing. So whenever you select the inputs tab, like different package, this automatically updates. So if you go up, what you would see is basically the benefits and the costs of that selected program. So if you go to the saved scenarios tab, Sylvia, there, just click save current scenario, please. And then say, okay, then it saved your selection already, your package. Now go back to the inputs tab, please. Yeah, now change it. Let's say, oh, we want, in terms of the type of program, now we want telemedicine. So can you choose psychological counseling, please? Yeah, okay, now we want, let's say, a different type of organizational model for the rare disease. Okay, let's say it is public-private partnership. And in terms of the method, let's say it is virtual. Can you click on virtual, please? And then frequency is monthly, for instance. And then let's say 4-hour interaction, like the duration is for 4 hours. And then it would require you to travel 50 kilometers and above. And the cost per session is, you change it to 10, something like that. Okay, and then click and view results. And by the way, before you calculate and view results, there is another drop-down menu, as you can see there, which says state. These are like the different Australian states. But for your case, what you can do is like, what if we consider the different European countries? So you can do this kind of comparisons by country. So that is also possible. Now just select none for now, and then you simply click calculate and view results. And then you see the uptake is quite small. This is 30%, and then there is a dynamically changing recommendation. Okay, you should do this, you should do that. So as I said, this is a kind of online decision aid tool. Now cancel that, and then if you go to the cost benefit tab again, yeah, so you see different cost benefits. So the net benefit would definitely be different now. Okay, now if you go to the saved scenarios, yeah, saved scenarios above, and then click save current scenario. Yeah, and then you see, then basically what I'm trying to tell you is like, you can create your own package of program care for rare disease, for instance. So what if I have these combinations? What is the benefit? What is the predicted uptake? And then you can do quite a number of scenarios, many possibilities. You can create those combinations by yourself. And then if you want, you can export to PDF, and then you can compare different programs. So which program of care should I provide? What is the cost of that program? What is the benefit? You can do those kind of calculations based on those results. At least, this tells you, like, it gives you like some insights into how we can use the discrete choice experiment results for policy purposes. So I'm sure I'm left with one more slide. If you come back to the slides, please, Sylvia. Yeah. Yeah, just to summarize, this is an important kind of methodology. So can you click next, please? All the points, please. Yeah. So what I was trying to tell you is that discrete choice experiments can help us capture these kind of complex organizational preferences, and specifically for this rare disease context, it's really useful given the limited number of sample size for this context. It really helps us because it's, respondents make repeated choices, and then the number of observations that we get from the repeated choices is larger, and then that's really helpful in order to give us some reliable results. And then I was trying to show you also the scorecard step, which is it's not like a necessary step, but it is useful in order to kind of make kind of stakeholder driven decisions, and of course to kind of limit the number of attributes to something that is manageable for the respondents. And then you can use these results in order to directly inform the different organizational models. And like I was trying to show you the last slide, the outputs of the DC results can be embedded in practical online decision tools that I was trying to show you. And of course, you can use these results as a benefit measure and in economic evaluations like cost benefit analysis. Yeah, that's all I have for today. Thank you very much for joining, and I hope you learned something out of this. You can contact me if you would like to know more about this. Yeah, I think we can open the floor for discussion, question and answer, please.
We can close the meeting, but first I would like to thank you, Mesfin, for your time and for preparing the webinar. And I think all of us, we catch all the important points regarding the advantages of the DCA. And I think it's important to test it on rare disease. So also thanks to Rauchan that is working on it now. And yes, if Luca wants to add something, otherwise I will just...
No, I would like to thank you again, Mesfin. I think that the presentation was really interesting and stimulating. And I think that it is now up to us to see what we can catch and what we can apply and what kind of modification. For instance, if we want to go deeper in the cost-effective model, how we can proceed in order to use the different determinants and how we can improve and adapt it to the rare disease, because obviously we will need a certain amount of activity and definition on what can be the necessary modification to this model, because I don't think it would be possible to adapt this model as it is to the rare disease, but the general architecture could be extremely interesting. Thank you very much for your attention and for your attendance. And well, we will have very soon an appointment in order to deeply discuss this aspect altogether.
Thank you.